back to do another episode on blood cancers. And today we're happy to have with us here our own Kristine, Abueg. Nurse navigator for hematology section. But she is so much more than that.
Oh yeah, she is way more than that. She authored multiple books regarding OCN, oncology nursing. She wrote chapters on immunotherapy and core curriculum. She also wrote some chapters in benign hematology in the Manual of Advanced Oncology Nursing Practice. So if you want to become a nurse practitioner, you know who to call. Yeah, also she's one of the authors of the Chemo Provider course. So it's time for us to renew. How are you doing, Miss Kristine?
I am well. How are you guys?
We're good.
Beyond excited
to have you here.
Yeah, what a pleasure. My dream has came true.
And today we're going to talk about multiple myeloma.
Yes, we are.
Yeah.
All right.
So, for our first question, can you tell us more? What is multiple myeloma, the pathophysiology behind it?
I would love to. I just want to say that since we're presenting this at the staff meeting on Thursday, I put together slides and handouts that go along with this today, and so we'll distribute those, and so you can follow along.
It's $5 each.
Payable to
Venmo. At Ian's dash.
Alright, so multiple myeloma, it's a little bit harder to conceptualize than a lot of other cancers because it's not a solid tumor, and it's not like lymphoma where you see a mass. So multiple myeloma, the best way to start thinking about it is a disease. Which camera am I looking at, by the way? That one? No? The best way to think of multiple myeloma as disease is to think about what the normal cell is. So multiple myeloma, when you break it down, is a cancer of the plasma cell. A plasma cell is that part of your bone marrow that makes, ultimately, antibodies. So multiple myeloma is a cancer of the factory that makes antibodies. So in your normal body, you create a lot of antibodies to everything you create, everything you interact with, so you have a whole complement of defense. But in multiple myeloma, the plasma cell gets a mutation, so it just creates the same antibody over and over and over and over and over and over again. So the problem with that is you have a mass production of one antibody, you crush out the production of all the other antibodies, so you got just one antibody you're making, nothing else is being covered, nothing else is being protected. The second part of that problem is that those antibodies are broken. So rather than being functional, you just get bits and pieces of antibodies and a huge quantity of them. And so that's a problem. You don't want a lot of broken stuff. So what happens is these broken bits of antibodies precipitate out into the urine, into the kidney destruction. They precipitate into bone, so bone destruction. And then, of course, they clump together, and so they get tumors. So bottom line is myeloma is overproduction of antibody bits and pieces. That's the way I like to think about it. And those things clot up everything and can cause a lot of problems.
Right,
that kind of leads into our next question is the reason people seek medical help before their diagnosis. Is that because of the kidney problems?
That's a great question.
Bone
problems.
Mm-hmm.
So patients who get diagnosed with myeloma, the typical course of action is they've had a prolonged back pain or just fatigue that just doesn't seem to go away. They're irritable.
Ooh.
They're tired. They get short of breath easy on exercise. I know this sounds like normal aging or your everyday life. So they go for a checkup and they go to the doctor. I just don't feel well. My back hurts, and doesn't matter if I sleep well or exercise, and the tongue doesn't work, and I'm always tired and I'm grumpy, and I mentioned my back hurts and all kinds of things. And so primary care doctors will usually do a workup, CBC. And then they're trained to know that if these are some of the persistent problems, to also look at some other lab tests and to see if we have evidence of myeloma. And so the presenting symptoms most commonly are back pain, fatigue, and shortness of breath, and then their lab test will show some anemia.
I see.
Is there like a time frame usually when patients start to feel those symptoms?
It's hard. So what I've observed with myeloma is that the start of the disease is pretty slow for most patients. And so these are the kind of patients who've been bouncing around for years just going, oh, I'm getting tired, my back hurts. It's just because I'm 50 or just because I'm 60. Because myeloma, typically, average age of onset is in your late 60s. And so you're thinking, I'm just tired from aging. Yeah. And so those symptoms can be progressing for quite a while very slowly over the course of several months and several years, and you might not ever really pay attention to them until one day just say, I'm just tired, or a fracture happens, bone pain is really persistent, and so that's when we tend to find it. So if we go to ER, patients will typically present like with really profound anemia or bone fractures, and the X-ray will show they have lytic bone fractures. And so the time frame can be fairly long, can be very slow oftentimes.
In terms of risk factors, who do you think are the common ones that get multiple myeloma?
So the risk factors of myeloma are, it tends to be more men than female.
I see.
It tends to be more Black Americans or of African descent versus Caucasians, and more Caucasians than Asian.
Okay.
So Black male, age is the big one. So if you're older in your late 60s, that tends to be the big trigger. Unfortunately, we can't change anything about that. Obesity, smoking, and of course all the big blood cancer risk factors, ionizing radiation, chemical exposure, things like that.
So previous cancer or
there's a
cancer
small
treatment?
Not so much. That's more leukemia than it is myeloma. But there is a small percentage of patients who have a risk factor from family history. That's very
well, that's
scale.
in the picture too. I see. So, could anybody age 40 and less than 40 years old, can they have multiple myeloma?
Certainly it's happened, but from the data I've read from the IMF, it's very rare. Very rare. So if you look at I think of all our patients with myeloma, they tend to be older.
60 for
right, they're all over 60.
Yeah.
And whatnot.
Yeah.
I see.
What other tests, you mentioned the CBC, that's primary care, what other tests are used to diagnose it? Or,
Right, so for myeloma, the defining test, the tests you need to really rule it out are first the CBC with a differential, you need a calcium with an albumin, okay? And I'll talk about that in a minute. Calcium with albumin, you need a serum creatinine, you need LDH and beta microglobulin just to kind of check the general body out. And then we'll run a test called the kappa and lambda light chains. And that's a simple blood test. And the kappa and lambda light chains, what they are the broken bits of antibody.
Okay.
So when the antibody kind of falls apart, there's a part called that's the light chain, and there's a part called that's heavy chain. And so in that assay, the kappa lambda light chains, we're measuring how much you have. Typically in a healthy individual, the kappa chain should be about equal to the lambda chains. All right? So you got about equal proportion. But when you're talking about cancer and you're making one copy of the same antibody over and 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 over again, one of those values will be overproduced. So your kappa chains might be in like the thousands, and your lambda might be 10.
I see. So that's like
so when
prominent.
Exactly. And so when we see an elevated light chain, that's when we typically get a referral from the primary care doctors and say, elevated light chains, please evaluate.
I see.
And then that's when we dig deeper.
And what do we do? What's the definitive?
So after we do that test, the next test we'll often do is called a serum protein electrophoresis. And that's where we take the blood and measure the proportions of different kinds of proteins in the blood. If you have a whole variety of antibodies, you should see a little bit of a lot of different kinds of proteins because you got a lot of different antibodies, right? But if you're making one antibody over and over and over and over again, you're going to see one protein sky high. And so it's called the M spike.
M spike, yeah.
Because you'll see the graph, what they're looking at is proportion of different proteins. And they should be all about kind of the same because you all have a lot of different kinds of proteins. But if you're making one copy over and over and over again, you're going to see one protein spike really tall. And so that test, the SPEC test, is where we can measure is there a protein that really kind of sticks out.
I see.
And so that's the test that we'll run, and that's when we see an M protein spike. And so that's the next test.
Why is it called an M protein?
M stands for myeloma.
Myeloma.
Or monoclonal gammopathy.
Spell that.
A monoclonal protein. And so then if we see that, typically the docs will then do a bone marrow at that time. The bone marrow biopsy will show that the bone marrow's got way more plasma cells than we normally would. Because again, you're making one plasma cell over and over and over and over and over again. You normally have a lower proportion, maybe 5%, but if the plasma cells in your bone marrow like on the 60% range, something's not normal. So that's usually one of the defining events for myeloma.
Okay. And then
we'll also do. Sorry.
Yes, go ahead.
No.
Yeah,
Yes.
Your voice is important than ours.
Agree.
Then we'll often do some sort of imaging to see if they got bone lesions. So let me step back for a moment and talk about some of the 4 big symptoms of myeloma, and those are the CRAB features. CRAB. So again, remember myeloma, you got this massive amount of plasma cells inside the bone marrow. Well, they're going to start interacting with everything inside the bone. They're going to make the bones start changing, so they'll start bone destruction. So you'll see holes in the bone. So in an x-ray, you'll see like little holes in the bones. Not like the bones are thinning. It's like there's like Swiss cheese in the bones. So that's the B in CRAB. And then because the bones are literally being dissolved, bones are made of calcium, right? So then you get your calcium levels leaving the bone into the blood, and so you get really high calcium levels, which is why we use Zometa.
There we go. You answered another question.
Because you're trying to pull the calcium back from the bone. I'm sorry, calcium out of the blood
and put it
back to the bone.
So the calcium is like high in the bloodstream. So that's where you get the elevated C in CRAB. So you got the C being calcium, the B being bone. And so the R in CRAB stands for renal, because all those broken bits of antibody, they start precipitating out of the kidneys and cause kidney damage. So we have a lot of patients who present with kidney failure at first. So that's the R. And then anemia, because the bone marrow just has no room to make red blood cells.
I see, yeah.
So C, hypercalcemia, R, renal failure, A, anemia, B, bone disease.
Does renal function improve with Zometa's?
Yes. So renal function will improve with treatment. Yeah, with treatment it improves significantly. The calcium levels improve with the Zometa. If a patient's in renal failure to begin with, that will change the start of treatment, what choice of drug we'll use. And you can really see a significant improvement. You can track it. You say, oh, calcium, the renal failure is improving, and and Dr. Nair or Dr. Law will often switch them to another regimen when they feel like it's better.
I see.
Okay.
If it doesn't get better, do they do dialysis?
We have. It's not very common because the drugs usually work, and usually if we're at that point of dialysis, we need to do it. Then we're having other discussions at that point too. But I mean, I've seen it. Not very common.
Not very common.
And then you wanted to mention something about calcium albumin. You
Oh,
kind of
yes.
did.
So remember, your calcium, this isn't so much an issue for us. So whenever you measure calcium levels, you always have to measure albumin as well, corrected calcium levels, because they affect each other, but our lab accounts for that. So when you look at our calcium levels, it's usually corrected for albumin. But you'll see us always order albumin as part of our lab values.
I see.
They kind of go together.
Mm-hmm.
All right, and then so you already mentioned the treatment, because there are a lot of treatments, multiple treatments for multiple myeloma. And you mentioned that kidney function is one of the determining factors.
Yeah,
Is
where we
there
start.
Anything else?
Yeah, so determining factors for myeloma, by and large, is it okay if I talk about the drugs?
Please.
Yeah.
Okay.
Yes.
Love it. Yeah.
So, in your handout, there are, I only really covered the primary drugs that we use more often. There's a few others that Dr. Nair will particularly use in addition to these, but very uncommonly. So for myeloma, the 4 major classes of drug we'll use are dexamethasone, the IMIDs, which are the immunomodulatory agents, which is Revlimid and Pomalyst, which are pills, the proteasome inhibitors, which are Velcade and Kyprolis, and the monoclonal antibodies, which are daratumumab and isatuximab. So we'll use a combination of these regimens. For the majority of patients, we will start out with a Velcade, Revlimid, and dexamethasone. Recently, there's been some suggestion, some good data from something called the Griffin trial, where the suggestion is to do daratumumab, Velcade, Revlimid, and dexamethasone. So we might see more of that. But so we generally start off with that regimen. However, if your kidneys are not quite great yet, we might actually start with Cytoxan first and let your kidneys improve, and then move on to one of these regimens. So the determining factors on where we start are, kidney function, and then we'll start with RVD. RVD stands for Revlimid, Velcade, Decadron. If your genetics show that you're high risk because of certain mutations, then we might add on a different drug on top of it called isatuximab. Why would we add it later? That's because the test where we do the genetics takes like 2.5 weeks. And so you might have already started the Velcade by that point. And so 2-3 weeks later, your doctor's calling you, we're going to add a different drug. And that's because the lab test or the genetics came back and it shows that you might be at high risk because you have certain mutations. And if that's the case, they might add on a different drug. Not because your disease has gotten worse. It's because the genetic test has told us something additional about your disease. And so the data shows we should add on isatuximab or daratumumab.
Nice.
You included it in your PowerPoint, the dexamethasone. Can you talk about the importance of dexamethasone
Also, the
all
question
of these?
came from Tennessee too.
Oh, from Tennessee.
Yeah.
That question
Hi, Tennessee.
came all the way from Tennessee.
Heidi.
Hi, Heidi.
Yeah, but
We miss you.
We do.
yeah, you do have the same mind with Tatiana and myself.
What's the deal with the Dex?
What's the deal with
Why
the Dex?
is everyone on Decadron?
Okay, I'm going to read it because I was researching this and I thought, I'm just going to flat out read it. Why Dex in myeloma? Because it has the transactivation to the glucocorticoid response element and transpression of NF-kappa B and phosphorylation of RFTK, PIK2, and induction of BIM. It works.
It works.
So the data has shown for decades that Dex works by killing myeloma cells, and it's really, really helpful for nausea.
Yeah.
So it works.
Okay.
The question I get probably the most about dexamethasone from patients, okay, Kristine, I feel really good on the days I get dex. Can I just take it every day?
Right.
Like I totally get it, but the long-term consequences of dex therapy are not great. So that's why we try not to encourage daily dex.
I see.
Yeah. Or there are those who are like, oh, I don't like taking Decadron. Can you just cut it?
Cut it all together, exactly. Yeah, so there's a lot of patients who don't want to take Decadron for sure.
Yeah.
And our docs are really exceptional about tailoring it to that individual patient.
Yeah,
for sure.
We have seen that. So, how long do patients normally have to be on these treatments?
Great
Is there-
question. So the reality about myeloma so far is, as of today, it's not curable.
Okay.
Even with bone marrow transplant, the majority of patients are going to recur. And so it's going to be a lifetime disease. So the fact it's not curable, however, we have so many treatments now that are pretty darn effective that you can live quite a long time with myeloma. So they're probably going to be on treatment for literally the rest of their lives.
These treatments, I'm so sorry.
Yeah, these
Okay.
treatments. Even after you go to bone marrow transplant, you're still going to be on maintenance Revlimid, or there's a clinical trial that's going on now looking at maintenance Revlimid plus daratumumab for a short period of time, for 2 years, which they consider a short period of time. So as of right now, it's kind of a lifetime situation.
I see. So these combination medications, these are mostly given to everyone, or some patient. I see some patients only get like Velcade
Yeah.
only every week.
Yeah,
Hmm?
yeah. So there are some patient will the physicians will look at a patient and determine their fitness level,
Okay.
you know, how healthy they are, and whether we can go to the full dose Velcade, or whether we need to go, it's called Velcade or RVD light, which is lower dosing of the regimens and the lower dosing of the drugs, and change the schedule so they're not getting as much drug. The goal is we're trying to maintain their quality of life for as long as possible.
I see.
And so the dosing might change depending on what that patient's function is. So, but all along the way, as we're doing these treatments, we're measuring their SPEP.
Okay.
We're measuring their light chains.
Mm-hmm.
And if those start, and we do that about once a month. The big
Okay.
thing for patients is, my labs look great, I'm being cured. But we haven't measured their SPEP or
Kappa.
the kappa
Mhm.
lap change. We only do those once every 2 months or 1 month or so. If those look like they're becoming high again, then that's called a recurrence or progression. And that's when the docs will change drug.
I see.
They might change from Velcade to carfilzomib, to Kyprolis.
Mm-hmm.
They might add isatuximab.
Mhm.
They might change from Revlimid to Pomalyst, which
I
is
see.
the other oral drug.
And
Oh.
sorry, who qualifies for bone marrow? Is it everybody or?
No, so that's a really good question, and it's from what I'm understanding. And bone marrow is intense. I once had a patient tell me, and he went through a successful autologous bone marrow transplant. It's like they take you to the edge
Yeah.
because they have to do melphalan and really, really crash their bone marrow, and then they do the autologous transplant. It's not for everyone. Not everyone can tolerate that.
Okay.
So docs have to determine whether this patient is transplant eligible by their fitness and the likelihood that they can tolerate it. A lot of it has to do with age. A lot of it has to do with just their general fitness. I mean, is it appropriate to offer bone marrow transplant to a patient who's 78 years old and
Right.
frail?
Right.
All right. Kristine, going back to the drugs. Last time I heard you mention about how the medications work. Could you help us
Sure.
understand that better?
Where would you like me to start, Ian?
Whichever. Yeah. So how does the medication work?
Okay, so on your handout.
Mm-hmm.
So Dex is the first one. So the next page is the proteasome inhibitors, and these are the ones we're probably the most familiar with.
Yes.
And that's Velcade, bortezomib, and carfilzomib, Kyprolis. So they're proteasome inhibitors. So what does that mean? What do they inhibit? A normal cell will produce proteins inside of it. But you don't want too many proteins inside the cell, because then it's like getting overly cluttered, and then the cell ruptures. So proteasomes are like housekeepers. They work in a normal cell, and they eat up the extra broken protein, and they recycle it. So then the cell stays nice and neat. Kind of like, all those guys who come in and organize your house.
It's me.
That's great. But however, proteasomes still do that to cancer cells, so that they keep cancer cells nice and healthy.
I see.
We don't want that.
Okay.
So the proteasome inhibitors stop proteasome, and so for the cancer cell can accumulate a lot of extra protein, which then allows it to die. So the proteasome inhibitors are like the cleaning ladies. Without them, the cell would get messy and rupture and die. The proteasome inhibitors, Velcade and Kyprolis, allow the cell to get sloppy, messy, and overfilled, so then it dies.
So that they can die. Okay, so that's the Velcade and the Kyprolis. I see.
So a couple tips about Velcade Kyprolis. The big thing with Velcade is neuropathy. So we really need to make sure we're monitoring that. So if a patient has pre-existing neuropathy, then we'll start with a different drug. And then so Velcade is usually first line. And then if the patient becomes refractory to that, or their disease is worsening, then we'll often switch to carfilzomib next, depending on what the situation is. And then Nilaro is an oral therapy that we've used rarely, but it is out on the market too.
I see.
And then for Velcade and Kyprolis, why are they taking acyclovir?
Great question. So Velcade and Kyprolis, they can suppress your body's ability to fight viruses, specific things like shingles. So it's really important that these patients stay on acyclovir as long as the physician recommends it, so they don't get shingles, because you don't want myeloma and shingles. No bueno.
That's mean.
That is mean. So a lot of times what we'll do is we'll also actually routinely we'll check hepatitis levels before they start, just to make sure that if they have risk of hepatitis, we address that. And so if they do have previous hepatitis exposure, we'll put them on the Baraclude or the entecavir, and then they should stay also on the acyclovir, so there's no viral infection.
I see.
But it's not a reason to hold chemo, right?
Correct.
Okay.
Correct. We'll hold chemo if their liver panels are wacky.
All right. Yeah.
Very interesting.
So that's the proteasome inhibitors.
Very nice.
Thank you, Ian.
I'm learning. Starting today. I'm just kidding.
A big foundation of myeloma treatment are called the IMiDs, which stands for immunomodulatory agent. You can't say that 3 times fast. So IMiDs. The 2 big ones we use are lenalidomide and then pomalidomide. They work by either killing this cancer cell directly, which is useful. They have specific targets, or they can work with the molecules around the tumor to activate immune response against the tumor. So they activate immune response and they kill tumor directly. So these are the pills patients are on. They're probably going to be on some form of this for literally the rest of their lives. And it's tough. It's really tough. Since we in the infusion clinic, we probably don't see this much because patients are taking it home. So patients still might ask you questions. So let me take this time to kind of familiarize you with some of the high points. First and foremost, this is not a drug that they can pick up at the pharmacy.
Okay.
So patients say, I'm out of my Revlimid, they're not going to pick it up downstairs. It has to be sent to them specifically. It gets FedExed to them by our specialty pharmacist and lands on their doorstep.
Okay.
And it's what's called the REMS program, so it has to be monitored because they're very high risk for birth defects. So they have to be enrolled by our pharmacist in the program, and then every time they get refilled, the physicians and the MAs have to confirm certain things, and then it gets sent by specialty pharmacy. I prefer that they start these drugs on the same day they start their infusions, because the cycle is either every day for 21 days and then off, and so it's just easier to keep track of if you got on the same day as the infusions.
Yeah.
Exactly.
Thank you for clarifying about pharmacy because that does come up a lot.
Like, where do I get my Revlimid?
Yeah.
You have to. It will show up at your doorstep.
Yeah. And then do they ask for a refill or is it something the pharmacy keeps track of?
Usually the pharmacy keeps track of it, so the specialty pharmacy will usually keep track of it and let the physician they're due for a refill. The good thing about it too is the pill bottles that they send the patient, if say it's like a day 1 to 21 dose for day 1 to 21 Q28 days, the bottle they'll get will literally only have 21 pills in it. So they can't go beyond the prescription. But then it'll magically reappear. Right, exactly.
Okay.
So those are the IMIDs. And then the big ones, as everyone's really excited about, are the anti-CD38, which is daratumumab and isatuximab. Daratumumab, cetuximab, they hit CD38, which is a molecule on the surface of plasma cells. They hit it just like any other antibody would and just destroy it rather rapidly. Daratumumab is indicated for first-line therapy, so you might see it with Velcade. And isatuximab is if they, right now is if they relapse. Again, viral infections are really important, so we protect for those. And the big ask I have as a navigator, so these drugs will really interfere with our ability to type them appropriately. Figure out what the blood type is.
Yes.
So it's really critical that before this drug hits their body, we have done a special type and cross to determine their blood type. Save that in the system. And you'll know it's been done if it says in their order set and their problem list is special transfusion needed. This is something that we, the navigators, would typically do. But certainly I would ask that before you start a patient, just make sure that's in there. And if it hasn't been done, please let me know immediately, and then we can draw those labs before they start.
Very good. Yeah.
Very important to know.
Yep.
Yeah.
All right. Any
What
questions?
is the prognosis like usually once they start treatment? How?
It kind of depends on the risk factors and their overall general health to begin with. So we certainly have patients who do quite well, but again, they'll be on treatment for pretty much ever. Some form of treatment. If we can get them to, I know Dr. Nair in particular, and Dr. Law as well too, if they're healthy enough and we can get them into relapse, not relapse, into response, meaning that their myeloma is completely responded, they have no more M protein that we can detect, their light chains have stabilized, their bone marrow looks clean, let's send them to transplant. Because that offers the best hope for long-term survival.
Nice. Wow, Kristine. Anyway, you have another question? Anyway, so as partnership between us and Fusion Nurses, you as a nurse navigator, to take care of the patients better, what do you want to tell us? What advice do you want to tell us, or what important notes do you want to tell us nurses, so that both our line of care to the patient is the same, straightforward, and quality? There's quality in it.
Well, first of all, I really want to thank all our infusion nurses and everybody. It's so hard to be the face of it all, and I am just so very grateful for everyone who cares for these patients greatly. So I hope I say that, but in case you haven't heard me say it, I'm incredibly grateful. I think that our patients will. The biggest struggle we have for a lot of our myeloma patients is that it's just tiring. It's just a grind. And then to think, a lot of our solid tumor patients, there's an end in sight for them. You finish your 12 weeks or whatever.
Yeah.
You ring the bell, you take your picture, and you're done.
Yeah.
That's not the case for these folks. And so it is a grind. And so oftentimes if we can address any fatigue issues or just a psychological fatigue that they're having ahead of time. If you hear that patients are getting tired of something or they're having neuropathy, that's kind of a big one. If they're having chronic infections, things like that, rashes, viral infections, let us know, and so we can intervene sooner than later. Because certainly as a lifetime therapy, we have opportunities to try and mitigate the discomfort so they can kind of be there as long as we possibly can. And CAR T. I mentioned CAR T. So CAR T therapy, chimeric antigen receptor therapy, is starting to be done for myeloma patients, and that's where we take the patient's own immune cells that we know are effective against their own cancer, and try and expand upon that and genetically engineer that T cell and reinfuse it back to the patient. So we've had a few patients going through CAR T for myeloma, and so patients ask all the time, "Oh, I'm just going to go to this center to that center, and I'm going to get this therapy." 99% of the time, we are already doing that therapy. So please know that's already being considered for them.
Do you have to also suppress their immune system for that, for CAR T?
Anyway,
Lots of information.
yes, my nose is bleeding again.
Yeah.
Anyway, Kristine.
Thank you so much for
thank
being
you guys.
here.
I'm honored, humbled.
I love asking you questions, by the way.
Right.
It's my daily question.
Daily question.
appointment.
Yeah, so I hope that answers most of our questions here. If there's none and you still want some more, then that's gonna be another topic. So without further ado, I give all the props to Kristine. Thank you for
You guys
doing
need
such
like a
a great
YouTube
job.
tagline.
Yeah.
Who said they did a YouTube tagline, right?
Yeah, if you have any comments or suggestions about a tagline, please don't hesitate to
know.
write
Got
us.
Zelton merch and the whole thing.
Alright, well,
Have a good day.
have a good day and thank you, Kristine.
Till
Till we meet again
Like in
tomorrow.
about 10 minutes.
Tomorrow.
Thank you.